Thank you. Thank you very much. So I am doing the talk on constipation, and then we'll have Rachel Webb on infectious diseases in children, and then we'll let you escape for your Saturday. Now, the reason I'm doing this talk is because as the GP liaison at Counties Manukau, I'm constantly told by the paediatricians that there is considerable overflow of constipation into their outpatient clinic. And Christine, could you please do something about this? So constipation in my mind is very much a primary care problem, and so I do like to talk about it at these meetings. It is a very common and debilitating problem, and I was recently the medic at my daughter's school camp, which I'm sure all of you have done at some stage, is that you get called upon at your kids' school camps to be the medic. And it was not till the end of the camp that the head teacher told me that they'd been managing one child at that camp the entire time who had had constipation, had overflow, messed his pants repeatedly throughout the days. The teachers had been busy washing his clothes for him, and actually the teachers had even given him some clothes to wear, and had not even thought to mention it to me. Having said that, the teacher went with an extensive list of what needed to happen for that child that long weekend, and the parents were to take the child to the GP pretty urgently, please, because it was a long weekend. It was a great opportunity. But I think that we probably underappreciate the effects of constipation on our children. And constipation, I think, is creating quite a lot of distress for some children, and we've certainly seen examples through the clinic where 13-year-olds have stopped attending school because they can't manage their symptoms and are too embarrassed, or nobody's sort of really understood exactly what was going on for them. So interesting, I went looking for some evidence of the prevalence of constipation in our children, and I found a study, sort of international study, which sort of says it's somewhere between 1% and 30%. But they changed the criteria in 2006 and actually broadened the category because it required a sort of a shorter period of time. And they talk about 8 weeks symptoms for that diagnosis. But I think in primary care, we have to be very alert to the children who are having some symptoms of even shorter duration, that we're actually addressing those issues really early, because otherwise they become chronic issues. So really important. But they basically come down to these sort of, I've really compressed the Rome 3 criteria, but really infrequent, hard, painful, large stools. Incontinence of stool is a really big red flag. If they've got sloppy, smelly stuff, then it's really something that needs some attention and some significant follow-up. Also stool retention in the rectum. So they've got big, hard stools in the rectum. So this is some more local data in New Zealand, and it shows that constipation, I know it's slightly older, 2003 to 2007, but actually I understand it really hasn't changed, is that constipation is a cause of hospital admission, 2% of hospital admissions, which is kind of crazy because actually most constipation is functional, and this is something that we could be managing in primary care. And when kids need to be admitted to hospital with constipation, it is quite concerning that they have got to that stage of seriousness. So what is a healthy bowel? And thank you for Claire for this. It's a daily or at least 3 not painful stools per week. And I think that's really important because actually kids can have symptoms. The pain is often what's stopping them passing emotion. So it really just requires a really good history. The bowel motions should be smooth and shaped like a sausage, and I'll show you Claire's version of the Bristol stool chart. You shouldn't really require it to strain hard to pass a stool. It shouldn't bleed when you pass the motion, and there shouldn't be leakage or incontinence of stools. And no consistent change in the bowel habits. So everybody varies from day to day, somewhat, some more than others, but we're really looking for those ones that are developing the more persistent problems. And in my experience as a GP, it can sometimes come on after a long period of, they might have had several days of fever and dehydration, and that can often be the start of something like that happening. So constipation is not an infant who grunts and turns red-faced and then has a soft stool. And I've seen a lot of that in my time as a GP. Parents concerned that baby is constipated. Baby's not actually constipated. It's pretty normal to do that as a baby, and quite a proportion of babies will have that sort of behaviour while passing a stool. And we also see quite a lot in the breastfed infants who have large, soft or one loose stool per 7 to 10 days. Remembering that breast milk is incredibly efficient as a food. It doesn't create a huge amount of waste product. And so babies can be completely and utterly normal and only passing a stool every 7 days or so. And if they are feeding well, they're getting plenty of wet nappies and they're otherwise pretty content apart from that fairly significant once every 7 days event, they're usually fine. But abdominal pain is not normal, and neither is fever, significant vomiting, loss of weight, or a red jelly stool. And you need to be thinking of some other things. And then also thinking about stool avoidance, which may or may not go with constipation, but it is a sort of a situation in those toddlers and those toilet training kids where you really need to take quite an extended approach to the behaviour management in that situation. And I'm not going to go into that in a lot of detail, but there is plenty of resources on managing that behaviour of stool avoidance. These are the toddlers that go and hide and poop, or they will try and manage to not poop and things like that, okay? And it often does coexist with constipation, but it needs some pretty specific management. Claire's sort of put this slide in, and I think that what we sort of are realising, there has been an increase in constipation, and I think these things are really important. The increase in processed foods, less fruit and veggies, and the sedentary lifestyle. Our kids are spending a lot less time being active, and that activity is really, really important to stimulate the bowel. It's also a lack of water, so it's important that when kids go to school, they know where their water supply is and they have their water bottle. Too much milk or dairy products can cause some constipation. But I think the final point is really, really important. It's that rushed and lack of time. It's all us parents trying to get out of the door in the morning and not giving the kids the time to sit on the toilet after their breakfast in the morning. We're kind of shoving them through their breakfast and shoving them out the door. I mean, I don't know if I'm a typical mother, but that seems to be, and we're not really giving them the relaxed time. And anyone who has kids that go to school know that the school toilets are not the most appealing places to do your number twos, let alone number ones, as my kids tell me. So really important when you're assessing a child, often you might find often constipation may or may not be the primary reason for them attending, but it's really important if you do get the idea that constipation might be going on, that you actually make time to find out exactly what's going on and tackle it early. Early intervention is far better than waiting till later times to sort it out once it's become an established pattern. So the timeline's really important. If things that the parents have tried, patterns and behaviours, pain or bleeding, overflow, personal family history, social and lifestyle factors. And in the examinations on the health pathways, you keep on getting told today, I've briefed the speakers really well today about that. You're basically trying to rule out any other issues that might be contributing to constipation, like celiac disease and things like that. But actually the vast majority of cases of constipation is functional constipation. It is not anything else. So apparently we're not allowed to put the Bristol stool chart on our health pathways, otherwise we need to pay every time you look at it. So this is Claire's version, which you're welcome to use anytime, anywhere, anyhow. Okay, type 3 and 4 are normal. Apparently this actually works really well with our Kiwi kids. They understand that. And just understanding that, making sure when you're taking that history that you're not talking about overflow and the kids talking about like kind of number 6 or 7, which is actually the overflow, that sneaky poo that gets around the solid poo. So just be careful that you're not misinterpreting what they're saying about their stool. The Poo In You is a really, really excellent resource. This is a poor kid at the playground, and they didn't actually film some poor kid in the playground, but he's messed his pants. He's about to go down the slide, so it's not pleasant for anybody. So the Poo In You is a really, really excellent resource, and actually it's a hyperlink, so when you get these slides you can click on that, but you can just Google it, okay? And it's a really excellent 5-minute video clip on what constipation with overflow is, and it shows you exactly what happens with food and where it goes and why constipation occurs and why constipation with that sneaky poo occurs. And it's really, really helpful because it's just actually, once you understand it, you understand why it takes a long time for that bowel that becomes baggy and saggy with that constipation and that big, that mass of poo in the rectum, why it takes time for the bowel to retrain and to get back into a normal size. So the big issues with constipation is it can be quite a chronic, intermittent condition, and it often starts in the preschool years. And managing it early and managing it well is really, really important for that child. The issues that Claire is seeing when she's doing her clinic in the communities, we've got children who are attending school who are still needing to wear nappies or pull-ups to school, which is a problem for that child for various reasons, and the child is bullied and excluded at school. If you ask your kids, they'll often know the stinky kid in the class. So I've talked to my daughter about, she's recognised there is a kid that has this problem in her class, and it's really, really alienating for these children. It's terrible. They've got the younger ones who will only poo in their nappy despite the fact actually having control. There's a lot of issues around health literacy and understanding the medication administration, and it's worth investing the time to do that. And also remembering that bedwetting and incontinence of urine can be because of constipation, and always be thinking about that. And the other issue is if we don't support, we might do some medication, and I've quite often seen this on the outpatient referral letters that come through to the paediatricians, that often something's been started, and I can trace back and look to the medication prescribing guys. Something's been started but it hasn't been sustained. It's really clear that they're not getting sustained management of their constipation. So success looks like well-educated parents, and they need to know that this is going to take some time to sort out. Encourage them to be in undies at school. Take a step-by-step approach, and this is for the younger ones especially. And there's lots of resources this on Continence New Zealand site about how to get those toddlers out of the nappies and managing well, and understand the importance of not stopping your medications and weekly phone calls to support. So I think you guys have all seen this before. This is on the health pathways, and this is the action plan that we designed about 4 years ago. Which you can use to support that. This lends itself very well to nurse-led model of care. Remember to use disimpaction when you need to, okay? So if somebody is significantly impacted with overflow, you'll need to do disimpaction and plan that well for a long weekend, for example. There is plenty of advice on the pathway about how to do that, and you've got a couple of different options now for medications that are funded to do that. Okay, and really important to follow that up with medication for maintenance. As I said, nurse-led care, and Claire actually does a clinic. She does a clinic which is often virtual out in South Auckland to manage some of this, but this is something that could be very well done in your practice. It'll be good to get somebody expert at this and to manage this. So really just a matter of following up, making sure things are happening. So this is just an example of one of the girls that Claire has been involved in caring for, a 9-year-old girl. She's had long-standing constipation with an exacerbation in the last 3 years. So this kid's been bothered by this for a long time. Wears pads due to soiling. She's unhappy and isolated, like we talked about at school. Kids don't want to play with her because she smells. And she's not been particularly consistent with taking those Macrogol sachets. And she's having a bowel motion every 10 days, which probably is really painful and unpleasant. So under Claire's guidance, she was started on 1.5 Macrogol sachets per day, and a week later she was having a bowel motion every day, and then she dropped back a bit because her bowel motions were a little bit loose, and then she's managing really well on 1 sachet. And this all occurs because actually you've given good education to both the child and the parent, and they are invested in making this work, and that time spent to do that is really good. And I think the point about this one too is that she didn't have to go through the whole disimpaction. Just loosening the stool with those Macrogol sachets worked really, really well. And it is about finding the right medication to work with that child. So lactulose is not the only thing that you can choose now, and there are plenty of things that you can do. There's lots of that medication on the health pathway. So yeah, it makes for a really, really different child. And I've got to say, I used to be the local GP for the school where my child goes to, and I used to care for one of her friends. She doesn't know this, but anyway, she had terrible constipation. And this child now with well-managed constipation, I see her 3 years later, she's gone from a very shy child to a really, really involved child. It's amazing the difference it can make to a child having this managed well. Okay, and here are all the resources. There is really good stuff on Continence New Zealand website, but just remember that if you do have a child with significant problems and the parents are trying to manage this through the process of good management of their constipation with overflow, they may need some products to manage that continence issues, and so make sure that you do utilise resources to assist the family to do that. Okay, now I think I will hand over to Rachel, who's going to do the final session.